Hello, everybody, again. So you can see that's my name, Andreas Reiter. I come from the University Hospital in Mannheim. Mannheim is close to Frankfurt, and my center belongs to the Heidelberg University. And, I'm working, sometimes I feel 101% in MPN. So almost every minute of my working life, I work with patients suffering from MPN and also doing like Anna diagnosis, molecular diagnosis in these patients. So I think all my colleagues would agree that myelofibrosis is certainly the most complicated myeloproliferative neoplasms. And you see this is a very busy slide, so don't worry. So this is the slide, this is our journey we will take during my talk. So we will start at diagnosis of the disease with the clinical features, and we will end with the potential allogeneic stem cell transplantation in generally a minority of the patients. So again, before I've already apologized for not being a native speaker. Now I want to apologize that my talk may be for some of you boring because they have known many things, but for others, many things may be new, and therefore I really start at the very beginning, and I apologize to those of you who know all that because others also want to get really the knowledge of symptoms, spleen size, mutations, and everything. And I really want to give you a picture of this disease in the next 30 minutes. And of course, it all starts with you feeling that something is wrong. And this is usually this term, what we call fatigue. You may feel that your spleen has become big. You may have problems with eating, that you feel full after really only, not the same amount of food you could take in. Night sweats are a problem. Sometimes also weight loss, weight loss plus night sweats. And again, it's usually always the combination of symptoms. So you go to your doctor, you may mention your spleen, the doctor may examine you, and you may find out, okay, my spleen is enlarged. And I have to say, if I was a general practitioner, an enlarged spleen usually means something. So this is nothing, you have to check that out. And an enlarged spleen usually is really hinting to a hematologic, whatever, neoplasm disease. Could also be a benign disease. And then, of course, we take a blood sample, and I just kept it as it is. So patients usually say, I have poor blood counts. So that's how it is. And again, it's just the combination of symptoms, enlarged spleen, and blood counts that leads us to the suspicion of having you a myeloproliferative neoplasm. So that's completely different, for example, to an enlarged lymph node. If you had an enlarged lymph node, we would suspect something like a lymph node disease or a lymph node neoplasm or lymphoma, how we call it. And then when we see you, we will ask you a lot of questions, particularly about your history, about your current feeling. Do you see, as Claire just said, doctors do not investigate the legs. So we have to investigate the whole patient. We have to do an ultrasound. We have to ask you a lot of questions about a history of infections, itching. Do you have any bleedings on some parts of your body? Or did you have, some thromboembolic event? And this is also about myocardial infarction, stroke. Do you have, problems with your fingers when it is cold? That you feel something may be wrong with your vascular system. And then, we will really try to make, a very clear picture of your symptoms. And I have to say, I've been now in hematology for 25 years. And let me say, until the last 5 years, if we saw a patient with MPN, we were only interested in blood counts and the spleen size. And it's really, just because of Ruben Mesa's work, fantastic work over the last 10 years, that we have realized that so many patients have so many symptoms. So, and it's not only one. So if we put it into statistics, patients suffer from up to 5, 6, 7 symptoms. And these are all the symptoms I have already mentioned, like, weight loss, fever, bone pain, itching. And you see, there's in fact not really a difference between PV, myelofibrosis, and ET. So this is very important, the careful scanning of the symptoms, because this becomes also important during treatment of the disease. And I also want to say something about the spleen size, because I've realized that many patients, they've never heard about the spleen. I mean, the spleen is an organ. We can really live without it. So we can remove the spleen and nothing really happens. And the spleen has usually the size of a fist or the volume of a Coke can, about 300 milliliter. And the spleen can increase, particularly with myelofibrosis, to enormous size. So in median, it is with myelofibrosis, it is between 2 and 4 kilogram. And we know after surgery that some patients have a spleen weight of 8 to 10 milligrams. So this is really this very big spleen in the tummy. And this, of course, causes a lot of problems. So then what about blood counts? I mean, you have already heard about, that the white blood cells platelets can be increased, cells can also be decreased, and already the blood counts tells us something. So, for example, patients with, at the beginning, with myelofibrosis can have leukocytosis and thrombocytosis. They usually have no elevated hemoglobin, so that would be more related to PV. But patients may also have anemia. And then this disease changes this picture over time. So while at the beginning the patient may have leukocytosis and thrombocytosis, the longer the disease exists, it gets to less. So patients then have, we call that leukocytopenia, so the number of white blood cells is too low, low neutrophils, anemia, sometimes transfusion-dependent anemia, and also low platelets. We call that thrombocytopenia, and sometimes we even need to transfuse platelets. So, and then, we have already spoken in the panel discussion about that, we need the bone marrow biopsy. And, well, sometimes I could think that it was invented in my country, because we are so obsessed with bone marrow biopsies. And as Claire has said, there has been an ongoing battle between the UK and the German pathologists, not the hematologists. We like each other very much. So, about the need of bone marrow biopsy. But finally, it is also a very individual decision. And as I said before, I think sometimes it is very useful to have a first biopsy to compare it. But if we want to diagnose myelofibrosis, we definitely need the bone marrow biopsy, because bone marrow biopsy is the only possibility to say that there's fibrosis in the bone marrow. Without, it is not working. So now I want to explain you a little bit about the bone marrow and blood. So now you would see normal counts in the blood. So you would have leukocytes of 10,000, and hemoglobin of less than 16, and platelets are, depending on the lab, usually less than 400,000. And this is the picture now in general in myeloproliferative neoplasms. So you have an increase of leukocytes, you can have an increase of the red cells, and an increase of the platelets. The leukocytes up to 400,000, the hemoglobin up to 20, 22, hematocrit 70, 75%, and platelets, I do not know what the record holder is, but it could easily be 4, 5 million platelets, even without symptoms. So this is also, so, and then as an expert, you already get a feeling, and it's again this combination, you know, the combination. So if the platelets are 400, the leukocytes 400,000, it's most likely CML. If the platelets are 4 million, it's most likely ET. But the difficulty is in between. So, and that means then we have to take the bone marrow biopsy. And, you know, myelofibrosis means something, when I explain it to my patients, you know, your bone marrow is like a sponge. You know, you buy a sponge, new one, very soft. And myelofibrosis means something like a calcified sponge, you know. You find the sponge again somewhere and it is really very hard, sometimes even very, very calcified. And so, and when we take a bone marrow biopsy, it's actually the same. So when we do the biopsy, so we can take some fluid out of that. But if the bone marrow is fibrotic, sclerotic, or calcified, you know, it's almost white like China, and we cannot take the aspirate. Then we have to take the bone marrow biopsy. And the reason are really these fibers. The fibers are even sclerosis of the bone marrow. And the problem is that these fibers are getting more and more. And with more and more fibers, you have less and less blood production in the bone marrow. And all the blood is produced in the bone marrow. The bone marrow is actually an organ. And this organ has to produce 5 liters of blood, you know, which is in your body. So increasing fibrosis causes less and less production of blood. And then you have the problem that you have all these so-called cytopenia, leukocytopenia, anemia, and thrombocytopenia. And finally, you know, after having investigated you, having done the ultrasound for the spleen size, the blood count, we do genetic analysis. This is not really interesting, let me say formally for you, but it helps us really to make the correct diagnosis. We can do that from peripheral blood, and then you know about these mutations. We have spoken about that. Usually I would not have presented it, but I think it is, I mean, you know all that, so that's really good. So CHEK2 mutation, chireticulin, and it helps us. And now you see, I really like this slide really very much because you see on the top is PV, polycythemia vera. And in polycythemia vera, you usually only have CHEK2 mutations. And at the bottom, you can see that the strong relationship between essential thrombocythemia and primary myelofibrosis, and that these patients can also have other mutations, chireticulin. But for your management, it makes not really a very big difference, whatever mutation you have. We may have, you know, some different views, whether we do some anticoagulation or not, whether we use aspirin, but in general, it makes no difference. And then just a word about primary myelofibrosis and prefibrotic myelofibrosis. We have spoken about that already. This is now absolutely the task of the pathologist. So we need a bone marrow biopsy to make this diagnosis and also this differentiation. So this is not a task of the clinician, and it depends on the amount of fibrosis in your bone marrow. But as I've said already, so this prefibrotic myelofibrosis, so Anna is talking after my talk about essential thrombocythemia. I'm not sure whether she's also going to talk about that a little bit. But to be honest, I mean, as I said, I really, even if in some of my patients the pathologist says this is prefibrotic myelofibrosis, and on the other side, if it is to me somehow clear essential thrombocythemia, I really keep sometimes in my letter both diagnoses. So I do not want to scare my patients then with, you know, with saying you have now prefibrotic myelofibrosis, because, you know, patients look into the internet, they think the prognosis is worse. And I very openly discuss it with the patients. And I think the chapter on prefibrotic myelofibrosis is not yet closed. So we are at the very beginning, and it may really change over time. So you should not be too worried about if you may have a change in your diagnosis. So talk to your hematologist, and he will make that very clear to you. So now coming back to our initial slide, you know, to the complicated one. We have started now here. So the patient has the clinical features like splenomegaly, the symptoms, and some sort of cytopenia. Then we have done, the bone marrow biopsy, we have done the mutation analysis, and it is also important whether you had ET or PV prior to my bone marrow biopsy, because then we would call it secondary myelofibrosis. If we diagnose the disease without a history of ET or PV, we call it primary myelofibrosis. But again, for us and for you in the treatment of your disease, it's not really a big difference whether you have primary or secondary myelofibrosis. And this is also a very important point, and I think we have to very openly discuss that with the patients. We use so-called prognostic markers. And prognostic markers are just, we somehow try to quantify the disease. And with this quantification, we really have to make the decision whether we do nothing, we call that watch and wait, maybe for 1, 2, 3 years, or whether we tell you, okay, we should search for a donor, we should go for allogeneic stem cell transplantation. So you see, watch and wait on one side, allogeneic stem cell transplantation on the other side. And for this decision, we really need markers, because otherwise we cannot do it. And, the quality and the quantity of the disease is best characterized, for example, about the presence of symptoms, whether your hemoglobin is already very low, whether your leukocytes are very high, and whether the blasts in peripheral blood are present or not. And, this then the so-called scoring, to put these factors into like an Excel table, then we get a picture of, and this is what I tell my patients and also my younger doctors. So if you see a patient with myelofibrosis, we have to answer 2 questions. Number 1 is, are you a candidate for a JAK inhibitor? At the moment in Europe, only ruxolitinib. In US is now also fedratinib approved, and we may also see approval of fedratinib in the foreseeable future, also of other tyrosine kinase inhibitors. And question number 2 is to the patient, are you a candidate for allogeneic stem cell transplantation? So, and this is, we can, it also depends on approval of the drugs. And that means, whatever risk score you have, we use this risk scoring systems to decide, A, whether we treat you at all, whether we use or can use or are allowed to use ruxolitinib, or whether we go for a transplant, maybe immediately, maybe after a short course of treatment, for example, with ruxolitinib. So this is then, after the presentation, the diagnosis, we assess the risk score. And there are many at the moment already existing, at least 8. So we also have risk scoring systems for the availability of allogeneic stem cell transplantation. But this is even too complicated for the regular hematologist. And also we have to look it up all the time in books, in the internet. So this is complicated and we use it, internet is very good just to calculate the score of the individual patient. And then we decide whether you are a low-risk patient or an intermediate 1-risk patient. So no anemia, no leukocytosis, you're younger than 65 years, you have no symptoms, or whether you have signs and symptoms like splenomegaly, or whether you are even an intermediate 2 or high-risk patient based on whether you have, for example, anemia or blasts in the peripheral blood. And then we have many treatment options. And there's number 1 is, and I really want to put it here at first place because there are still patients in whom we do nothing. We just say watch and wait. Low risk, intermediate risk, without symptoms, you may still be able to fulfill everything you want to do in your daily clinical life. You have 100% fit for going to work. So we may do nothing. Then the question is always whether to use aspirin or not. Also, myelofibrosis is a disease where you are at risk for thromboembolic complications. You may have already had a thromboembolic complication, and we have to also discuss aspirin. Again, in many situations, our drug number one is hydroxyurea. So Jean-Jacques has already left, so he's also in favor of interferon in myelofibrosis. I think it is really difficult drug in myelofibrosis, so maybe in very early phase, but not really in later phases. Then danazol, we have discussed it. And then, of course, drug absolutely number two at the moment is ruxolitinib. I've said that already. Then we have to ask the question about allogeneic stem cell transplantation. And then, very important in the course of the disease, the so-called supportive care. So we may use erythropoietin. This is a drug which the cyclists like to take, to make the Tour de France, to increase the hemoglobin. But yeah, half, they have calculated half of the worldwide erythropoietin production, half is only going to patients. And nobody knows, or they say they do not know where the other half of the production goes. But you know where it is. And, the problem is that even, let me say the non-professionals, cyclists like me, for example, they sometimes also take erythropoietin to increase their, their fitness in cycling or running. So, okay, erythropoietin may be important, and then transfusions of red cells, platelets, and of course treatment of infections. And then, I mentioned that already, we should have to decide, ruxolitinib or maybe even allogeneic stem cell transplantation. And this is in fact a very, very difficult question. And we have said that already many times, we need data, evidence-based medicine, guidelines, but we do not really know what to do. Should we first use, for example, ruxolitinib? Should we try to get you in a very good remission and then to go for the transplant? Should we go for the transplant immediately because you are at a very high risk of progression? But this is very rarely the case, very rarely the case. So when you are on ruxolitinib and you're doing very well on ruxolitinib, then you may ask me, okay, why should I now go for the transplant? I'm feeling very well, So it means, should we do the transplant in the best possible remission? Or should we just wait until the disease shows signs of progression? We may have very soon drugs like fedratinib, you may have heard about it, available. So you may get the second chance to use another check inhibitor to get again into remission and then to do the transplantation. And this is all taken from chronic myeloid leukemia, a disease in which we have several of these kinase inhibitors available, and even there it is not yet answered when really to perform, what is the best time to perform, if at all, the allogeneic stem cell transplantation. And it may really take some more years, 5-10 years, until we have really a clear picture about the road on treatment decisions. So now, after we have started ruxolitinib, what do we expect? We want, of course, to reduce the symptoms. So complete, night sweats, weight loss, so reduction of spleen size. And of course, the problem of ruxo is that the hemoglobin and the platelets may decrease. So this is the side effect. So this is what we would like to have. So reduction of symptoms, reduction of spleen size, and no effect on hemoglobin or platelets. But we can't get that. This is not possible. When we start ruxolitinib, we always have some side effects. But on the other side, it is very good that we never see this picture. So every patient has at least some sort of response on ruxolitinib. So the problem is it's very heterogeneous. And so there are again no guidelines on that. So it totally depends on your individual situation, the dose of ruxolitinib, for how long you take ruxolitinib, because the problem is if we want to get a better reduction of symptoms and a better reduction of the spleen size, we may have to increase the dose, and that may mean that the hemoglobin and the platelets worsen. And therefore, your doctors, they may start with whatever 2 times 15 milligram, then they reduce it to 2 times 10, then they increase it again. So this has all a reason. This is all, you want to have a maximum efficacy at the lowest possible side effects of the drug. And then we are here. So what happens if the disease is progressive? And I must say, so this is then very, very difficult to decide what to do. There are now a lot of second-line treatment options, but none of them has now really shown that it is better than ruxolitinib. And then here, it may really be the time then to think about the allogeneic stem cell transplantation. And there was already the question, allogeneic stem cell transplantation means I have to know the disease you have. I have to know about, we call that about your comorbidity, whether all your other organs are healthy, and I have to know something about your donor. And only in this pattern, we can then decide about what we do. And that's my final slide. At least in my country, it is really complicated because we have local hematologists and the university hospital to decide about treatment, clinical trials, also about transplant. You have genetics and pathology in different labs, and somebody must take control of that. And of course, in the center of all that really must be the patient. So you must really know where you go, and you must always inform the right people with the right information. And then you may really have a good time, even though you suffer from this disease. Thank you very much.